All right, so I would start by introducing myself to the patient.
So,
Um, Going to let them know that I'm a fifth year medical student, get consent for examining them and presenting my findings to my consultant. Then I'm going to go to the foot of the bed and inspect the patient.
mm,
Um, so on my inspection, I can do general inspection and more specific. So generally, I want to be looking at the patient for any obvious signs of a hyper or hyperfunctioning thyroid. So I'm looking for any if the patient is adequately dressed, if there's any fidgety movements or any signs of excessive thyroid activity. Looking then at the neck, I'm looking to see if there's any obvious swelling or any scars. Um And then from there, I could do the peripheral examination first. But before I get there, I could ask the patient to swallow from that point and protrude the tongue to see if
okay.
the mass moves
What's the
with
significance of it?
swallowing. So, a thyroid mass, because of its attachment via the ligament or
No,
berry,
I don't need you to tell me the exact. Just tell me what's the significance of it.
so to separate a thyroglossaldosis from a true thyroid solely.
Okay. Which one moves up on swallowing? Which one moves up on protrusion of the tongue? Which one moves?
The The thyroglossaldosis would move with protrusion of the tongue, but both would move with swallowing.
Okay. Um. So they at the foot of the bed, you always give the patient some instruction, right? So remember that with every exam, or almost every exam, there's some instruction that you will tell the patient from the foot of the bed. Before you move from the foot of the bed, you ask yourself, what is it that I need to ask the patient to do? If it's hernia exam, patient's gonna cough. If it's breast exam, they're gonna put up the hand. Akimbo, all of that maneuver. With thyroid, they're gonna ask the patient to swallow, stick out the tongue. All right, so there's always some to ask the patient to do from the foot of the bed. So we'll be looking out for that. All right, cool. So you make your general inspection. You do your general inspection, and you go closer to the patient. By the way, how is the patient positioned?
The patient could be seated or
Or they could be what?
lying supine.
Really?
Well, usually they're seated or
Sometimes they're lying supine too. How would you want the patient to be?
I don't want them to be seated up.
Right. They should be sitting up. All right. So it's not optional. So the thyroid exam is done in a seated position. All right. You can continue.
So I would do the peripheral examination first. So I'd start with the hands. I want to assess if there's any tremors. So I can have the patient put out the hand horizontally and have a piece of paper on the hand to see if there's any
Okay,
fine
we're going to go through
tremors.
that. You're going to check what tremors next.
I'm going to check for any clubbing. I'm going to check the hand for any excessive warmth of the hand or moisture, and then I'm going to go ahead and check the pulse and check for a collapsing pulse as well. Then I'm going to go to the eyes. So going to check for lid lag, lid retraction so in front of the patient, I'm checking for lid lag, lid retraction. I'm going to assess for ophthalmoplegia by making the H. And then behind the patient, I'm looking for any obvious proptosis or exophthalmos.
Okay,
And so while I'm behind the patient now, I can go ahead and ask permission to go palpate the neck. So
sure.
start
hmm
I'll start by assessing the thyroid gland and then I'm going to do the lymph nodes. So I'm going to start by
What's our definite
upper,
no in terms of when you're palpating?
don't compress bilaterally.
Right.
So
All right.
I'm going to apply some counter push on one side and then palpate on the opposite side. So
Mm-hmm.
could start, we said that the muscles on the right side. I could start with the unaffected side first. So I'm palpating to feel the make an assessment of the size. If there is tender or non-tender, if it's nodular or if it's diffuse. I want to know if it's going to ask the patient to swallow again to feel if I can get below the swelling. Um, Feeling if it is hard, I'm feeling so the consistency. I want to
Mm-hmm.
assess if it's tethered to any overlying or underlying structures.
Mm-hmm.
Um, and then so doing that bilateral, I'll be able to assess the mass, and then from there I can percuss to see if it has any retrosternal involvement and auscultate for any thyroid bruise. And
How do
then
you focus for external involvement?
so I would percuss from the sternum going up.
Right. So towards the thyroid. Mm-hmm. Okay. And so the important points, yes. I agree. One of the biggest things you're doing, yeah, well, as I usually say, with I need to know why you're doing what you're doing. Um, the biggest thing that you're trying to identify here, um, is to differentiate. Well, to see if there's any enlargement, to see the distribution of any enlargement. So if there's any nodule, so if it's multinodular, what are some of the things that can happen with the thyroid? I will move on to somebody else. We're not finished with the exam yet, but we'll move on to somebody else. What are some of the things that can happen with the thyroid gland? Need another volunteer. Another volunteer, please, quickly.
Excuse me, Dr. Thomas, you could repeat the question, please?
I'm asking what are some of the things that can happen with the thyroid gland? What are some of the pathologies that we're interested in? If you're not hearing me, let me know.
Sorry, doc. So you were trying to figure out if it's diffusely enlarged in terms of a Graves' disease, or if it's like multilobular. That's what you're asking.
Let me ask again. I'm asking what are the pathologies that can happen, what can occur with the thyroid gland? What are the different pathologies that we're interested in with the thyroid gland? It has nothing to do with this exam, the steps of the exam or anything. It's a general question. What are the pathologies that can happen with the thyroid gland? What we're interested in?
Point towards like your benign and your malignant conditions. So, like your benign conditions will be like your Graves' disease, Hashimoto's thyroiditis, and then like for the malignant, you're looking at the papillary, the follicular, um, carcinomas, the medullary cell carcinoma, anaplastic, carcinoma of the thyroid. That's that's one way to classify. Or type 1 and hyperthyroidism. That's all about it.
Okay. All right. So it's important to classify. As it pertains to surgery, we are interested in structural pathologies, right? So we're not too interested in the hyper and hypothyroid. That's medicine business, right? We're interested in the carcinomas, of course. Number one, and we have a list of those. Um, Multinodular goiter and Graves' disease. We'll talk about the indication for surgery for those. But the things that can go wrong with the thyroid, that's the general question I was asking. Because if you don't know, then you don't know what to look for. So each of those things have their different ways they will present. All right. So the the malignancies will present as a solitary nodule, right? Solitary nodule, usually, a single nodule you can feel on one side, or you may have more. Right, or you may have multinodular goiter where you have multiple nodules, bilaterally, or you may have Graves' disease where you have a diffuse goiter, one, you know, uniform swelling to the thyroid, right? So you can see the difference in terms of how they will present these three big conditions as it pertains to the thyroid gland. Now, you have differentials for the different conditions in the different patterns. So not all solitary nodule is going to be cancer, right? Not all the time that you have multiple nodule is going to be just multinodular goiter, and not all the time that you have a diffuse goiter is going to be Graves' disease. But it's important to know that Graves' disease presents with a diffuse goiter. Multinodular, um, multinodular goiter presents with multiple nodules, and cancer usually presents with a solitary nodule. So when we talk about a solitary nodule, the biggest thing that first thing that's on top of the differential is cancer, a solitary nodule. When we talk about multinodular goiter, yeah, when we talk about multiple nodules, of course, you'll be thinking about multinodular goiter. When we talk about a diffuse goiter, on top of the list is going to be Graves' disease. All right. So these will be supported by different investigations. Now, as we go back now to the exam, so say all of this because when you're doing the exam, these three things are going to be on top of your list. When you're busy about Hashimoto's and all those other fancy stuff, we're talking about the big hitters, right? Now, thyroiditis, yes, is another set of condition, right? Which, will present with its classic pain and such based on history. But we're talking about the big structural problems. So when you're doing the exam, that's what you're feeling for, essentially. So we're going back, we went off track a while ago. Let's go back to the exam. When you're doing the exam, that's what you're feeling for. You want to know, is this a solitary nodule, or is this multiple nodules, or is this a diffuse goiter? So we need to hear one out of the three classification in terms of the structure at the end of the exam. Or is it normal, right? So at the end of the exam, you need to determine whether or not this is a normal thyroid exam. Two, is this a solitary nodule? Is this multiple nodules? Or is this a diffuse goiter? Understand?
Yes, sir.
Okay. All right. So I've painted the picture already for you. So that this is a solitary nodule. All right. So solitary nodule to the right side. You've palpated. You've inspected. You've palpated. You've percussed. Anything else you want to do?
So I would have auscultated for the thyroid bruise and
Very
then
good.
assess the lymph nodes. So looking at assessing the cervical, supraclavicular, submandibular, submental, periauricular, postauricular, occipital, and then from there I can talk to patients and present to my consultant.
Right. So you check you palpate for the lymph node same time when you're doing the palpation for the thyroid. Right. So you're not going to auscultate and then go back to palpating. All right. So we've spoken about the pattern in terms of nodules, spoken about the associated lymph nodes, whether or not it's retrosternal, right? And so at the end of that exam, you're going to summarize, of course. I've already given you the main finding of solitary thyroid nodule, right lobe. I need somebody else now. Okay, very good, Baker. Next.
Hi, Dr. Summers.
Okay, Mitchell. All right, Mitchell. So you have a patient with a solitary thyroid nodule to the right lobe. It's about say 2 centimeter and non-tender, moves up with swallowing. Doesn't move on protrusion of the tongue. What's your assessment?
Okay, doc. So I am considering malignancy. So the most common of which would be
What percentage
a
of solitary
puncture.
thyroid nodule is malignant?
Doc, I don't recall right now, but I know it's a leading differential with it's more than 50%.
No, actually less than 10%. In fact, yeah, that's why I said less than 10%. So less than 10% of solitary thyroid nodule is malignant. 10% of solitary thyroid nodule um that's euthyroid is usually malignant. So of those solitary thyroid nodules, some can be hyperthyroid, some can be euthyroid, some can be hypothyroid. The euthyroid ones, meaning normal, no hyperfunctioning gland, there's no hyperthyroidism, no hypothyroidism, meaning cold nodule. Of the cold nodules, 10% of those will be malignant. So just small subset, but yes, it is the most concerning differential. And so yes, cancer should be um up there on the list. But it's important to know that they can ask you, you can see the MCQ, what percentage of a solitary thyroid nodule is malignant. 10% is not the answer. 10% of cold solitary thyroid nodule is malignant. So there's a difference. Mhm. Okay. So yeah, so it's a cancer. Cool. And I would ask you some differentials. If it's not cancer, what could it be?
It could be a cyst. No, it never moved over the tongue. Could be Hashimoto's
It could be a
thyroiditis.
cyst, it could be a thyroid cyst, yes. Mm-hmm. Why
It
we go to
could be
Hashimoto's thyroiditis? That's a
because that was,
solitary thyroid nodule.
yeah, I think that presented it.
Mm-hmm. All right, so your differential has to be, well, somebody said toxic adenoma. You'd have to prove some toxic symptoms or toxic signs, right? So if you're going to put toxic adenoma as a differential, you have to say, okay, this patient had tremors, they're fidgety, irritable, and they're low BMI, all of those things. So if you're gonna say toxic adenoma, which could be a differential, you have to support it with other signs or findings on your clinical exam. So for sure, if the patient displays features of hyperthyroidism, then you could, put that as a differential. In fact, you could put that as the first differential. That would be more likely than cancer. So if the patient is not euthyroid, if they have features of hyperthyroidism, then cancer can't be on top of the list because cancer don't present with hyperthyroidism. All right. So yes, you can continue. You said this patient is clinically, based on what you're seeing, the patient is euthyroid, and so you have to give me some euthyroid differentials. It has to add up.
You could also say lymphadenopathy.
Lymphadenopathy on the right lobe. Give me some thyroid differentials man, before you go to extra stuff. Talking
So
about
it could be a
thyroid,
color. It could be a colloid nodule.
alloid nodule. We're going fancy before you give me the regular stuff. But I want to hear stuff like dominant nodule and multinodular goiter. So you can have multinodular goiter that you can't feel. The nodules are very tiny. So not because you're not feeling nodules mean the patient don't have a multinodular goiter. So multinodular goiter with a dominant nodule is probably one of the more um, common differentials for a patient with just a solitary nodule on clinical exam. So I've stated before that the patterns are, you know, multiple nodules, diffuse goiter or solitary nodule or solitary nodule. But it's important to know that a solitary nodule on clinical exam doesn't necessarily mean that the patient only has a solitary nodule. It could be that the patient has multinodular goiter with a dominant nodule, right? Which is common, and that's why I'm making, you know, making it a big deal because it's common. For you to have multinodular goiter with a dominant nodule, could be a follicular adenoma. Somebody had said that in the chat. Yes, that is a euthyroid. You know, that can be euthyroid. So those are probably some of the more common differential. Follicular adenoma, uh, dominant nodule, multinodular goiter with dominant nodule, carcinoma. Uvula, just one nodule there. Okay. How would you manage the patient? Same person, Mitchell.
Okay, doc. Suppose taking a detailed history and examination. I'd want to go forward firstly. Hematological tests for the patients. I'd want to ensure I get
Sorry, you say
thyroid,
you went to take a what?
complete blood count as well
No,
as
no, no, no. Go back. You
a
started by
detailed
saying so.
history and examination, doc.
What does that end? Well, you did the examination a while ago. What
Yeah,
does the
and
detailed history involve?
okay, doc. So I want to know if the patient is having any features of hyper and hypothyroidism.
Excellent.
So as long as in the history, I want to know if there's any history of any surgeries to the thyroid region,
Mm-hmm.
any any recent illness or hospitalizations with any viral illnesses, doc. Uh,
Okay.
as well as I'm considering a family history of any cancers or any challenges there. Those are the
Okay.
main
Family history
points
of
that I want
thyroid.
to.
Mm-hmm. Anything else?
Those are, and I want to know risk factors if the patient has any exposure to any regions where there is iodine deficiency,
Mm-hmm.
or if the patient is having any presentation at present where they're having any trouble breathing or any compressive symptoms to note.
Okay. Good. All right. So in when you're thinking about history, and if you want to quickly just tell the examiner what you would include on history, just remember in every whatever condition it is, you're trying to elicit current symptoms. You're trying to elicit risk factor, right? Risk factors for whatever condition, right? And you want to see if there's any evolution in terms of the symptoms. So, I mean, the big things are really the risk factors and symptoms. Risk factors and symptoms. So, symptoms in this case, which you started out with perfectly, hypo or hyper thyroidism. Features of hypo or hyperthyroidism must ask the patient those, right? Nobody's gonna say what are the features, what are the hyperthyroid features. That's third year stuff. Nobody's gonna waste time on that. Know that you must ask about hyper and hypothyroidism symptoms. You're gonna ask about compressive symptoms. Remember the C's. Compressive symptoms, the dysphagia. Even if you don't go through each of them, you say compressive symptoms. Nobody's gonna say what are the compressive symptoms. You just leave it there and you move on. The compressive symptoms, and then you can look at risk factors. So the risk factors, of course, you're looking at family history. That's one of the biggest ones. Then the acquired risk factors, such as radiation, iodine deficiency, right? Exposure to radiation prior. All right. So these are, the main points. And you can reel it up in 10 seconds quickly. So that's your thorough history there. All right. And then now so based on your history and your examination, you can further, come up with the assessment. We've spoken about the assessment for your solitary thyroid nodule. Next person will take me through the investigations quickly.
Okay, I can go ahead.
All right, who's this, Miles?
Yes, Max.
All right, good.
So having taken a detailed history examine the patient, say that the patient have a solitary thyroid nodule. In terms of investigation, would like to do our thyroid function test, so TSH, T3, T4, as well as thyroid ultrasound.
Mm-hmm.
In terms of,
Anything special about the thyroid ultrasound?
so the thyroid ultrasound will tell us whether or not this would be a patient for biopsies of fine needle aspiration cytology.
Mm-hmm. But before you get to that, anything about the thyroid ultrasound? Any characteristics about the thyroid ultrasound itself? When you're requesting it on the request, you're going to request a special type of ultrasound.
Not entirely sure.
All right, so you're requesting a high frequency. No, not Doppler, but a high frequency neck ultrasound.
Okay.
High frequency neck ultrasound. So you want to distinguish between like parathyroid, thyroid, and other structures in the neck.
Okay.
Mm-hmm. All right, continue.
So
Having done the thyroid ultrasound and the thyroid function test, what's the next step?
if
What you
it's
looking for? What you looking? Why you do them? Yeah, you have to tell me why you do them. So quickly, don't ask that. Don't wait on the examiner to say why are we doing this ultrasound or what kind of ultrasound we're doing. I need to be at that point where I say, okay, I'm going to request high frequency neck ultrasound for X Y Z. This is going to give me a X score, and I'm going to do TFTs because I want to know if this patient is biochemically hypo, hyper, or euthyroid. Simple as that. I move on. That's the level that I want it to be at. So yes, we're doing the ultrasound.
right, so we're looking for anything that could indicate a malignancy, as well as to apply the thyroid score, because that is going to tell us whether or not this is a candidate for fine needle aspiration cytology. So if it comes back as a thyroid 3 to 5, then we'd proceed with fine needle aspiration cytology.
Okay, so the thyroid score give you the risk or the likelihood of this being malignant. Very good. All right. So and the TFTs. What TFTs? What specific tests you're going to request? Everything.
So if I had to choose one, I'd go with the TSH. But because the T3 is the most predominant form, so maybe TSH T3 if I had to choose.
Okay. So yeah. So the TSH alone is fine. In fact, TSH, yeah, so TSH alone, if it comes back hyper or hypo, then you can move on to the T3 and T4. All right. So the patient is euthyroid. TSH is normal, and the ultrasound confirms a solitary thyroid nodule. There's no other, nodules, and it's thyroid 4. Thyroid 4.
So if the if the thyroid function test comes back as euthyroid, then would have to do a radioactive uptake scan.
This is if it come back normal.
Right, euthyroid.
If you come back euthyroid, you do a radioactive scan.
Right now.
When would you do a fine needle aspiration?
So
When in this
if it's not
scenario?
to have a thyroid score between 3 to 5, then we proceed with a fine needle aspiration cytology.
Right, but I said this patient has a thyroid of 4.
Okay, so yes, we'll proceed to the fine needle aspiration cytology.
So you're going to do both. You're going to do the thyroid scan and you're going to do the fine needle aspiration cytology. You're going to do both?
So yeah.
Yeah, okay, all right. So I said no, you don't do both. There's never a situation where you do both fine needle aspiration and a thyroid scan. So everybody can pause. If you're washing your dishes, if you're watching TV or whatever, doing another lecture right now, pause right here. Probably the most important point. All right, so this is the juncture where when um when you're faced with a patient with an ultrasound, the patient has done an ultrasound and a TFT, right? You're now the decision now Up to this point, the patient is in the GP's office, right? Patient hasn't been referred to a specialist yet. Patient was been sent for the usual tests, TFTs and ultrasound. Regular, anybody with a thyroid problem will be sent for those things. Having gone back these tests, this is when you, as the person in the health center or the person in your GP office or wherever you are, this is when you're going to decide, does this patient go to medicine or does this patient go to surgery, right? Because both of we, all of we, manage patient with thyroid. But who do I send to surgery? Who do I send to medicine, right? So if the patient is euthyroid and has a thyroid score of more than 3, then the patient requires fine needle aspiration cytology. We don't stick a needle in a patient's neck if they're hyperthyroid. You'll go into thyroid storm. So if the patient has hyperthyroidism, if the TSH is low, meaning the patient is hyperthyroid, there's no role for FNAC in this patient. There's zero role for an FNAC in this patient who has hyperthyroidism or who has um, uh, low TSH, no evidence of um, hyperthyroidism, right? So no rule for a patient for FNAC in hyperthyroidism. No. If the patient is um, euthyroid, then yes, I mentioned FNAC. If the patient is hyperthyroid, this is where the patient does a thyroid scan, right? This is where the patient does a thyroid scan because you know that the patient has hyperthyroidism, but you're not sure what's the focus of the increase what's the focus of the increased production of thyroid hormone. It could be all over the thyroid gland, or it could be in one little place in that solitary nodule, or it could be another somewhere else, so the point of the thyroid scan is to see the distribution of the overproduction of the thyroid hormone. So it will tell us if the pattern of uptake is at the solitary thyroid nodule or if there's a diffuse uptake, right? And by uptake, I mean when they give the patient iodine, as in with the thyroid scan, the thyroid will basically hold on to it, right? Because it needs it to be making this thyroid hormone. So we use iodine. So it grabs onto this thyroid hormone, this iodine, and the scan will tell us which part of the thyroid gland is grabbing onto this iodine. So we just basically give the patient iodine. This is the thyroid scan we're talking about, thyroid scintigraphy. Give the patient iodine, and then we just watch and see who is gonna grab up this iodine. Now we're watching to see if this focus of increased activity is right at the nodule or if it is diffuse. This is when we're going to basically tell if this patient has Graves' disease or if this patient has a toxic nodule, or if patient has, in the case of multinodular goiter, have a multinodular goiter with a toxic nodule, right? So that's the reason why we do the thyroid scan. So the thyroid scan, you can put it in bold, is indicated in a patient who has hyperthyroidism because we want to see where the hungry cells are. Where are the ones that need all of the iodine to make the thyroid nodule. We want to see the pattern of uptake. That's the reason why we do thyroid scan. So guess who don't order thyroid scan? The surgeons. We don't order thyroid scan. Taking the surgery exam, it's usually not, we're not listening with a thyroid scan. If any you want to hear about, is the patient not going to be hyperthyroid, right? Hyperthyroid patients go where? To medicine. They go upstairs on ward 7 and 8, right? So we don't treat hyperthyroid patients downstairs. This is at UE. All right, so those patients go to medicine and they will do their thyroid scan, they will do their antibody test and all of those nice fancy stuff, right? We keep it simple downstairs. Yeah, so we just decide, look on the TFTs. Is this patient euthyroid? Of course, we'll get the euthyroid patients. and the ones with thyroid 3 or more. And then those patients will get FNAC. All right. So at this point, this is where we have divergence in terms of management. Surgeons get the euthyroid solitary nodule, whereas medicine gets the hyperthyroid, hypothyroid, the multinodular goiter, the Graves' disease, that kind of thing. All right. Clear, Miles?
Yes, Doc.
Okay. All right. So let's stick to the surgery side now. We'll leave that chapter with the scintigraphy to when you're reviewing medicine. So on
Okay.
the surgery side now, patient euthyroid, patient has thyroid 4, so we're going to be sticking a needle there. So FNAC. FNAC, somebody went at me from here. Take it from here. So what we're talking about, you're talking about the solitary thyroid nodule. Solitary thyroid nodule. Who's taking over? Who's next? Come on. Who's next? I'm not going to choose anybody. No, somebody just volunteer, please.
I
See
can
it is
answer
on.
it. I can answer it. What specifically about FNAC though then?
Sorry.
What specifically about the FNAC?
That's what we're going to ask the exam now. We
No.
said the patient has a thyroid 4. We said the patient has a thyroid 4 lesion and with FNAC. So you're going to take me from there in terms of the management of the patient.
Okay. So if
Here's
the
who Baker Wood
FNAC,
came already. Baker, no, Baker, you went already. Must be somebody else.
Okay, Doc, I can try.
Okay. All right. What's
So after the FNAC would use the Bethesda system to determine our next steps.
right? Good. So Bethesda is what I want to hear. Even if you don't remember the details of the Bethesda, the fact that you mentioned Bethesda and you reach to that point of Bethesda, you can breathe a sigh of relief. All right. So yes, you need to know the terms. Yeah, Bethesda is one of them that you have to know. Right. So you can now impress me. And go for distinction and honors. Honors and distinction with your description of Bethesda. So yeah, so you're going to tell me through the Bethesda score as far as you can take me. All right, let me tell you what the Bethesda comes back as, and what most likely will come back as if you get to this point. 3 Bethesda 3. What's Bethesda 3?
I think that's the one where you can't determine if it's follicular adenoma, carcinoma. So that's when you would do the you would have to go to surgery and take out a piece or
Gonna research yet? Gonna
oh,
research yet?
so we
No.
can't say if it's follicular adenoma or carcinoma. We can't determine on FNAC if it's a carcinoma or benign follicular adenoma.
Tell me the category first. Bethesda 3 is what? What name? It's category name. You have to know what name. If you don't know any other category, you know what Bethesda 3. What's Bethesda 3? Right,
I'm
so
looking.
quickly, all who don't know Bethesda 3, you're gonna Google it now. What is Bethesda 3? And you're gonna remember it. If you don't know any other category, you know what Bethesda how much? 3. 1, 2, 3. Not Bethesda 5, not Bethesda 6, but Bethesda what? 3. You're going to Google it and you're going to remember it. What's Bethesda 3? Somebody who knows Bethesda 3, tell me, please.
Typically often determine significant or follicular lesion of undetermined significance.
Go again. Who is it? Corey? Watts, we're going to come back to you shortly.
I
Corey,
was saying it
take
is
us through.
ATP of undetermined significance, or
Mm-hmm.
it can be also called follicular lesion of undetermined significance. It's AUS
Well,
or
it's not also called, the category
or
is,
sorry.
well,
Yes.
both AUS/FLUS. And it's an indeterminate. That's the overall term for it. The indeterminate. So AUS, ATP of undetermined significance, or follicular lesion of undetermined significance. All right. Before we move on, we're going to pause right there. We're going to stick a pin. Stick a pin right there. All right. So we're going to continue. We're going to pick up from there soon. I want 3 persons. What? We're coming back to you. Year 1. 3 people when who's willing to participate. Miles, I want you again, and 3 ladies. That is one
I'll
more.
participate, Doc.
All right, great. Okay, Graham. Good. Hi, Graham.
Hi.
So Graham, Miles, and Watts. All right. Um. So we're going to talk quickly about the 3 main types of carcinoma affecting the thyroid. Right. Now, I want each of you to be, so this is a kind of like a competition, right? You're going to describe yourself. Each of you going to describe yourself. We are in a kind of a beauty pageant, right? I'm the judge, right? So what you are, let's call you follicular um, neoplasm. It's, uh, well, you guys can choose. You choose. Graham, what you want to be? Papillary carcinoma. What? All right. Miles, follicular.
Okay.
And what's medullary? Okay. All right. The first contestant is, yes, Miss Thyroid Universe. Very good. All right. First contestant. Let's see what you have. We'll start with Miss Papillary.
Hi, good night, everyone. And my name is Miss Papillary
All right. Wait,
Thyroid.
before you get into your description and your introduction, I'll just guide you in terms of what we want to hear, what the audience wants to hear. They want to hear, where you're from, how, well, the risk factors, how you got there, where you, where you, where you want to go, meaning where you want to spread to, where you want to spread your wings, and yeah, your prognosis, how your future look bright or what, and who are your, who is this? Sorry. Yes. So yeah. So those are the main things I want to hear. If you want to tell us anything else, we don't reach the part where you start describing yourself yet. All right. So I don't want to hear about your beauty just yet. Just give me a little background when you reach the beauty part yet. All right. Let's go.
Okay, so my name is Miss Papillary Thyroid Carcinoma. I
Mhm.
am the most common out of all the thyroid carcinomas. I
The
fall
most
under,
the most popular. You in the
yes,
popularity contest? Okay. All right.
yes,
Fine.
popular for popular.
Very good.
And
Yes.
I fall under a differentiated thyroid carcinoma.
Mm-hmm.
I'm more common in females than males. And I
Mm-hmm.
have, my future is very bright. I
Hence why
have
we're
a,
having a pageant because no man is
yes,
in this competition. Yes.
my
All
future is
women.
very bright. I have a, 95% of persons who come in contact with me have a 10-year survival.
Okay, nice. Okay, good. Bright
Um,
future. You're not so aggressive. You seem a little calm,
yeah,
right?
we chilling over
Calm.
here.
Okay, you're calm. All right, cool.
It's
Calm and
often
popular. Say
seen.
popular around the place. Okay. All right, cool.
It's often seen in a slightly younger age groups around persons in their 30s and 40s. So that suggests a bit about me and my background.
Mm-hmm. Okay. What about the how did you get here?
So
How
in
you got here?
terms
Risk
of
factor. Mm-hmm.
so
Risk
what
factors.
exposure to like radiation, stuff like that.
Mm-hmm. Okay. So you live around nuclear plants and them things.
Yeah, Hiroshima.
Hiroshima, yes. Right. Chernobyl. Mm-hmm. All right. Okay, so radiation. So you have high radiation exposure. All right, and when you're in radiology suite, you don't wear your thing.
Yeah, careless like
The
that.
thyroid pitch. Yeah, you can't flex it. That you're too cool for that.
Yeah, too cool.
Too cool. All right, cool. Okay, so how you spread? Where you want to go?
So I really like the lymph nodes. I have a
Lymph node.
propensity for lymphatic
But
spread,
that's you're so
most
local
commonly.
though. Why you so
Yeah,
local? I thought you were
I don't
popular.
know. I'm trying to work on that, man, one day at a time, right? Trying to
Okay,
go
so
further.
okay. I thought you'd take a plane and go to another continent or something. You just staying around the town. You just popular around the town. You're not really popular then.
Oh Lord. Well, when you put it like that.
Okay.
Yeah.
All right. So papillary, yeah. So she's popular, very common, but she doesn't like to go too far. She likes to spread to the little lymph nodes around the place, but she won't get into the blood because she's not very aggressive. She's kind of calm. She won't get into the blood and go to the liver and the brain and those things, right? So, but she's calm. She will do her thing around the place, and um, she usually, people usually like her. She will, she will live a long life. All right, cool. All right, so that's Miss Papillary, Miss Follicular.
Thank you.
Thank you.
Okay, so good night, everyone. I'm Miss Follicular carcinoma. I'm usually associated with iodine deficiency. Unlike papillary,
Give me one
um,
second again. Give me a second. Okay. All right. Good. So we're at Miss Follicular now.
okay, so hi, good night,
Okay.
everyone. I'm Miss Follicular carcinoma. I'm usually associated with iodine deficiency. Unlike
Mhm.
papillary carcinoma, I like to spread my wings, so I usually spread via the blood to like the lung, the liver, and the bone. The second most common, unfortunately. Um,
That's a popular. Maybe that's a good thing because I hear you're a little aggressive there.
yeah.
Mm-hmm.
Um, when you look at me, when you look at my cells, I don't usually have the
No, when you're ready for the beauty part, yet. When you're ready for the beauty part. Mm-hmm.
okay. Um,
Beauty competition come. The beauty part coming next. The swimsuit and thing is the
okay.
next section. Mm-hmm. All right. So anything else you want to say? So risk factors. How you spread. What percentage of persons they
Um,
usually involved with?
about 10%, not
Yes,
20.
about 10%. All right, good. Miss Popular about 85 or so. All right, cool. So what about jeans? I hear you like to wear jeans.
Okay, so well,
Kind of jeans you
as
wear? What brand jeans you wear?
like P10 and you know
P10
the right
jeans, a big brand.
strategy. Yeah.
Okay, what other jeans? And even more expensive jeans.
Then my
Bigger
P10
jeans.
and
Than P and
Ross.
what? Russ? Okay, Russ. Yes,
10 and
yes, yes.
Ross.
Yeah, man, a big jeans at Russ. Yeah, man. Nice. Okay, P10 and Russ. Those are the jeans that Follicular will wear. Popular, you never tell us about the jeans that you like to wear.
Honestly, Doc, I prefer
She never your
skirts
jeans
and
on.
dresses.
Skirts and dresses. It's okay. You don't have to be ashamed. We know you bought them on Shein and such. But yes, what's the brand jeans? Most popular jean that you wear?
I'm actually not sure.
Okay, well, we catch
Yeah.
you there. I get a mark down. You're doing very well, but yes. So red PTC is actually the jeans that I hear that you like to wear. Red PTC. Red papillary thyroid carcinoma. So not just regular red genes, right? And yes, BRAF V600. Those are the two genes that you like to wear. Red PTC and BRAF V600. Very good. All right, good. Now we're going into the beauty section. Medullary, don't feel left out. It's going to come to you. You can just take it from, just take it away. It's popular. Back to you. So this is, remember, this is Miss the popular um contestant here who doesn't go very far, but she's popular. She's not so aggressive, and she likes to wear red PTC jeans and RAF in her V600. RAF, yeah. All right, come through. Ready?
Okay. Hi again,
You're
everyone.
describing yourself. You're gonna tell us how you look when you look under the microscope.
So, classically, I'm defined by certain nuclear features. So, namely, the orphan Annie nuclei, linear nuclear grooving, as well as pseudo inclusions. Um, you can also see something called somoma bodies, and these are calcified clumps, but they are not found in the nucleus. They're found in the cytoplasm, but they're not very specific for my condition. It can be seen in any type of papillary um, carcinoma anywhere in the body.
Okay, very good. So you realize she's, very confident in how she looks. She knows exactly, she knows her features very well, right? She knows she has orphan eyes. She knows she has this bodies, the calcification to the inclusion bodies, all of those things, right? Those classic features that we always talk about. They're describing her. They're describing papillary thyroid cancer. Very confident. She's popular. You know, don't go very far. Yeah, like she's a good girl, right? And she brought off in her V600 jeans and her red PTC. That's her, right? Very clear, very, distinct. When you look under the microscope, you know exactly what you're looking for. This is papillary. There's no two ways about it. We know exactly how she looks. We know exact the features down to the T. Now, for Miss Follicular, the aggressive one, right? Not so popular, but she loves to spread her wings. Mm-hmm. Miss Follicular, what we're going to see when you look under the microscope.
Okay, so usually when you look under the microscope for me, there's nothing where cytology is concerned, nothing fancy. Usually I don't have the
Nothing fancy.
typical popular feature. I have
You don't have no
atypical cells, but
features.
you need
You don't have no shape.
histology for me.
That's what he's saying. You don't have the shape. You don't have no features.
Not
See,
with cytology. You need histology for me.
oh, this is surgery for you. You're complex.
Yeah.
Why so complex? We can just keep it simple like Miss Papillary. You know, Miss Popular have shape. That's why she's popular. She have shape, and she, you know, calm. Unlike Miss Follicular, aggressive. She not so popular. She not no shape. She not look no
Just
way on the microscope. Not
just
impressive.
just atypical cells.
It's atypical cells. She
Yeah,
just boisterous, but we can't really tell what you are.
no.
So remember,
Histology.
so follicular. So for follicular, very good. So follicular, we can't really tell. We can't tell if follicular is if this is carcinoma or this is follicular adenoma. It's just, you know, and when you look on her cells, you won't see no shape, you won't see no fanciness. You can't say what it is. No read the shape. You just have to look on how she behave, right? If she's going to be invading into things, if she's gonna be, you know, bursting through walls and them kind of thing there. Just have to watch her good, right? So we can't really tell when we just see her alone. We can't really tell when we just see the cells alone. We have to see how she interact with her surroundings to tell, okay, she is very, very aggressive, like she's carcinoma, or she's not so aggressive, you know? So she's follicular adenoma, right? So follicular adenoma and follicular carcinoma will look the same way on cytology. Follicular adenoma, follicular carcinoma, both of them will look the same way on cytology. What will distinguish both is our observation of their behavior. Is she gonna be bursting through the walls? Right? Is she gonna be disrupting the environment? Or is she gonna be staying by herself and just, you know, be boisterous and atypical, like adenoma? Right? If she's gonna be bursting through things and behaving very aggressive, then she's carcinoma. How are we gonna tell if she is invading? And by bursting through walls, I'm talking about invading the capsule, right? How are we going to tell if she's invading the capsule or getting boisterous and moving through things? By histology. We're not going to tell that on cytology. Cytology is cells, as the name suggests. Cytology means cells. Histology, we're going to be looking at the walls, we're going to looking at the capsule and other things, the surrounding structures, the vessels, the nerves, etc. Right? And that's how we distinguish between a follicular adenoma, which is not normal. Adenoma is a neoplasm, right? It's a benign neoplasm, right? But it's a neoplasm nonetheless. And so we distinguish between an adenoma and a carcinoma, follicular carcinoma. All right. So that is the crux of the matter. If you don't remember anything else today, you remember papillary, has shape, has form, very confident, know exactly what it is. That's not going to fall in Bethesda 3. If you say Bethesda 3 is not papillary, not papillary carcinoma, we know it's not papillary carcinoma because papillary carcinoma will tell us that it is papillary carcinoma. Papillary carcinoma is very confident. Papillary carcinoma is going to be either 5 or 6. When you see papillary carcinoma, we know that it is papillary carcinoma. And we know that we know what to do, right? But who's going to fall into Bethesda 3 and 4? Follicular lesion of undetermined significance. What do we mean by undetermined significance? We know that Miss Follicular is over there, but we're not sure if Miss Follicular is bursting through the capsule. We're not sure. We know that there are some cells that are atypical, some follicular cells that are atypical, but we don't know what's happening, you know, in the surrounding. And so we can't tell if this is carcinoma because she don't really have no shape or anything, right? We just know it's atypical, but we're not sure. And so those the FNAC will come back as atypia of undetermined significance or follicular lesion of undetermined significance. Or Bethesda 4, which is follicular neoplasm. We know it's a neoplasm, but we're still not sure if it is adenoma or carcinoma. So I'll go back to Bethesda 3 and 4. This is indeterminate. And the whole point of this Bethesda 3 and 4 is really to determine, is this follicular adenoma or if it is follicular carcinoma. There are some other differentials, but by and large, those are the two big things that we're trying to differentiate. Follicular adenoma, follicular carcinoma. We know who's not going to be in that little group there. Indeterminate. Miss Papillary is not going to be there, right? Papillary carcinoma, we know. All right, good. So, Miss Watts, going back to you.
Hello.
Mm-hmm. You are following, I trust.
Yes.
You are following. Very good. Excellent. So, so we have a Bethesda 3. What are the differentials? What could this be?
So it could be a follicular adenoma, follicular carcinoma.
Excellent. You have more?
It couldn't be papillary, but it
Couldn't be
could
papillary.
could
Give
be
me 1
papillary.
second.
Could be.
Yes, sorry about that. So, yeah, so it could be follicular adenoma, follicular carcinoma. Now, how do we proceed from here?
Okay, so we'd have to do
Go again?
histology.
Histology. So we jump straight to histology. All right. So fine. I wouldn't mark it on for that. But before we jump to histology, you should repeat the FNAC.
Yes.
Repeat the FNAC, get some more cells, see if you see any distinguishing features. Right? You know, maybe in this catch you will see some orphan ani, some of my bodies, and you will say, okay, this atypical cell was really, papillary, but true, right? But before you jump to doing the histology, then you should repeat it.
Okay.
All right, there.
Yes, Doc.
But how do you get the histology though? So we repeat it and we get back the same thing. How do you get the histology? Give me a second. I'm not hearing you so well. Speaker is off. Give me 1 second. Right. So how would you get the histology?
Surgery, so a lobectomy
A lobectomy,
and send
diagnostic
it back.
lobectomy. So a
Yeah.
diagnostic lobectomy. That's how you get the sample and sorry, go clarify the timing. Sorry, I didn't see that question.
Well, I was asking.
Timing for the repeat. So within
Yes.
6 weeks or so, you repeat the FNAC. All right. So you're repeating because you want to give another chance to determine whether or not well, to see if it will come back as indeterminate or it will be a more definitive answer. Right? So repeat it, and then if it comes back as indeterminate, that's Bethesda 3 or 4, then we would move to diagnostic lobectomy. Stick a pin. So okay. So this is a classic question. Usually, the residents will get question like this, but yeah. Hello. Sorry, not sure if you're hearing.
We can hear you again, though.
Thank
You
you.
broke up before
Yeah, they
you
were. I was
started
getting a
asking the
call.
question.
Yeah, I was getting a call a while ago. You keep on calling me. Yeah. So I was saying, right? Well, when you repeat the FNAC, is there anything special that you can request in order um to determine whether or not a diagnostic lobectomy is really necessary? Because let me just put it out there. Very good, but we'll soon come to that. So let me put it there. Just like the last session where we spoke about breast, Z11 and all of that. I'm gonna paint the picture, the actual practical thing. So, a lot of persons will come back with Bethesda 3, right? When you do FNAC, and say we get 100 patients with Bethesda 3. We do FNAC every day, and we get back results every day, and it comes back showing Bethesda 3. When we repeat it, we get Bethesda 3 or 4, indeterminate. We will book all of these patients for diagnostic lobectomy. And when we do diagnostic lobectomy for kill, right? Them just full up the list, the operating list, right? Diagnostic lobectomy, day and night, right? Weeks and weeks and weeks. And then we get back the results, and maybe about two of them come back showing follicular carcinoma. And the rest of them, follicular adenoma. Right? So you'd have done 98 follicular adenoma and 2 follicular carcinoma. Now it feels like a waste, right? Like, is it really necessary to go through all of that? Take out the lobe of the right lobe or whatever lobe it is, do diagnostic lobectomy, go through anesthesia, everything, and the yield is low when it comes on to actual follicular carcinoma, right? So it is because of that, we've come up with newer methods to kind of determine who really needs diagnostic lobectomy, right? So I think Miles put in the group there that there's an option to use molecular testing. Molecular testing. So molecular testing basically is just sending some of the cells, right? Sending some of the cells to look what kind of genes they're wearing, right? So if them getting the BRAF brand or the P P right, the red PTC, the RAS or the P10, all of those things you want to see when you do the molecular testing, what line of genes them wearing. And if it's showing any of the high risk genes, the high risk genes associated with cancer, then these are the patients that you would actually do surgery on. If the patient can afford it, to do this test, this gene test, it's a genomic test, right? Or molecular test, same thing. It basically can decrease the amount of surgeries that we have to do, unnecessary surgery, that is, to just limit it to those who have high risk genes. So that's got molecular testing, and one of the types of molecular testing is thyroids. Not commonly done locally. I think it may be available at maybe one lab, but they're sent abroad. Usually sent abroad. So it's available. Anything is available once you can afford it. Once you can afford to send it where it is available. So yes, from time to time we'll send samples abroad for testing. So that same FNAC that you repeat in within 6 weeks time, you send a sample for molecular testing. If you don't remember the name of the molecular testing, don't remember the terms, just know that in addition to the FNAC, you will do, testing to look for high risk genes associated. Um, right. So that's to decrease the unnecessary surgeries associated, well, for diagnostic lobectomy. Okay, so we've gone through Bethesda, well, you just review the other categories for Bethesda, the suspicious, highly suspicious, malignant, and in terms of management, of course, you have a total thyroidectomy, near total thyroidectomy when it comes down to cancer, right? Also, so yeah, total or near total. For the papillary, you will do a prophylactic central lymph node dissection, right? So because papillary usually spreads to lymph node, we generally do a prophylactic central central neck lymph node dissection in addition to the thyroidectomy. Right. So if it is high risk, meaning there's any evidence of spread, then you want to do a total thyroidectomy, so that you can offer this patient ablative therapy or iodine ablation. Right. When you do a total thyroidectomy, remove the whole thyroid gland. So the only remnant of thyroid that would be left would be, anything that would have spread. When you do the ablative therapy, now this goes straight to those areas. It goes to the abnormal areas that you would have spread to, and basically ablate it to get rid of those metastatic disease or locally advanced disease. So that's indication for total thyroidectomy. Near total can be done, leaving back like a gram of thyroid if it is not, locally advanced, if it is, right, not metastatic, not locally advanced. In that case, where you don't need to give ablative iodine therapy. All right, because if you give ablative iodine therapy and you have remnant thyroid tissue there, normal remnant thyroid tissue is just gonna soak up all of that, and it will not, that it would not go to where it needs to go. Right, so you need to, if you're going to give ablative therapy, you have to remove everything. So that, in essence, I've stated the reasons for doing a total and the reasons for doing a near total. Near total, if you don't plan to give ablative therapy. Total, if you plan to give ablative therapy, ablative iodine therapy. How does ablative iodine therapy work? Ablative iodine therapy is just basically flood those thyroid tissue or follicular tissue with iodine. And actually, when you flood it with iodine, it does the opposite of what it's supposed to do. It basically shuts down the cell. Whereas it basically just it gets overworked basically, and it shuts down. So whereas it will, use a small amount of iodine to make thyroid hormone, when you flood it, like in the form of iodine therapy, it basically just shuts down those cells, and that's basically ablates the cell. So that's ablative iodine therapy. So we're talking about adjuvant treatment after surgery. Um, Indications for multinodular goiter, treatment of multinodular goiter. So these patients initially will be treated by, medicine. They will be sent to the surgery clinic, sent to the surgeon if they've failed medical management, meaning they have, like a toxic nodule with the multinodular goiter that's not responding to medical treatment, or if they have compressive symptoms. Compressive symptoms, those are really dysphagia, dyspnea, um, yeah, hoarseness. Well, hoarseness will indicate, malignancy. But those compressive symptoms, along with, if them just generally cosmetic wise, they don't want a nodule there. We're talking about multinodular goiter and surgery, right? So those, the C's, this is where the C's come in. The
Sorry, Doc.
C's.
Hi, Doc. Sorry to interrupt
Mhm,
you.
no
You said
problem.
for near total thyroidectomy, would you do ablative therapy or not?
You wouldn't do ablative therapy with a patient with near total thyroidectomy.
Just total thyroidectomy?
Sorry?
Just total
The-
thyroidectomy? Okay.
so let me state again, if you're planning to do ablative therapy, the patient has to get total thyroidectomy.
Okay, Doc. Thank
What
you.
will happen if you try to do ablative therapy and the patient had near total thyroidectomy. They have 1 gram of that normal thyroid gland in their neck. Left back intentionally by you, aka you did a near total thyroidectomy. What's going to happen when you give them radioactive iodine? What's going to happen when you give them that? Hmm? Not quite. You're not going to get thyroid storm. He's going to get distracted by the normal thyroid that's there.
Okay.
Meaning the normal thyroid is going to suck up everything, and where you want it to go, meaning why you giving it is because you want it to treat any remnant abnormal tissue that's around the place, like metastatic tissue, right, or locally advanced. But when you give it and you have normal thyroid here, thyroid gland that's left back in the neck, all of that is going to go to the normal thyroid, and it's not going to treat the metastatic disease that it's really supposed to treat, right?
Yes,
Or
doctor.
locally advanced disease. You basically get distracted by the normal thyroid, right? You get distracted. It's absorbed by it, and it basically works on that normal tissue instead of working on the abnormal tissue. So you don't want to leave back in the normal tissue there. You want to get rid of it and say, hey, go do your job and treat the abnormal tissue that's left back. That's what we're giving it for. To mop up any abnormal cells that's left back. All right, so you have to do a total thyroidectomy if you're going to give ablative therapy.
Doc,
Yes.
sorry to bring you back, but your choice of doing a sub near total or total thyroidectomy will be dependent on what?
Will be okay. So it depends on whether or not the patient has features of, but it depends on the type of thyroid carcinoma. So follicular is most likely going to be a total, right? More aggressive. A total thyroidectomy, and in those cases, you're going to give ablative therapy. But papillary, no, that's not so aggressive. These are the ones that you can give near total if it is, a T1 or T2 lesion without lymph node involvement. If you have lymph node involvement, clear evidence of lymph node involvement, those patients require a total. They need ablative therapy to get rid of those whatever deposits there are in the lymph nodes. You there?
Yes, sir. Clear. Thank you.
So anybody with evidence of lymph node involvement need total with ablative. All right, follicular, total. Locally advanced or METs, yes. All right, so right, so we're talking about the indications for surgery in multinodular goiter. The C's, this is where the C's come in. Remember C's from third year, compressive symptom cosmesis, cancer, concerns for cancer. And that works for Graves' disease also. If it's resistant to medical treatment, right? So Graves' disease resistant to medical treatment, or if you have a big, uh, thyroid there, goiter, that it's causing those same C's. So it works for multinodular goiter and Graves' disease, right? And if it is large, over 80 grams, so that's the indication. Those are the indications for surgery. All right, so
Question, doc.
clear. Mm-hmm.
So before we operate on the patient has to be euthyroid.
Yes, patient has to be euthyroid. So in those patients who are hard to control, there are some measures that are done pre-op, to get the thyroid hormone down in preparation for surgery. Mm-hmm.
Yep.
So the antithyroid drugs, the beta blocker, the corticosteroids, yeah, Lugol's and all of those things are some of the measures that we'd use. And those can be used in emergency setting too, like thyroid storm, if you have to do surgery in these patients.
Okay. By chance, if somebody say was refractory to medical therapy, could we and for like a Graves' disease, could radioactive iodine work instead of the surgery?
Yes, so radioactive iodine, medical treatment, radioactive iodine, and surgery, those are the three options for Graves' disease. In terms of first, second, third choice, it depends on the jurisdiction. America does one thing, Europe does one thing. I can't remember if I think America is more inclined to do radioactive iodine, whereas in Europe they bypass radioactive iodine and go surgery if medical management is has failed. But yeah, usually the drugs are the first thing, and then either radioactive iodine, and then surgery, or in some places they would just go straight to surgery. All right, so I think that we touched on the main points as it pertains to thyroid. Oh, we didn't go through medullary. Mm. But we can do that. We can probably just wrap that up quickly. Uh, wrap up thyroid quickly when we start the next session.
Doc,
Mm-hmm.
just to confirm, so if we have a patient who has done their FNAC and the Bethesda comes back to say that the patient is at Bethesda 3, which
Mm-hmm.
is the critical of undetermined significance, then those patients would need you said sorry biopsy
Go again.
for the patients who are Bethesda 3. Can you repeat what is done for those patients?
For Bethesda 3, miles just done for those patients.
Okay, so for Bethesda 3, you would repeat the FNAC in 6 months plus molecular testing.
6 weeks.
6 weeks, sorry, and then you do your molecular testing. If it's that it comes back as a Bethesda 3, then you do a diagnostic lobectomy.
Mm-hmm.
And
So if when you do the molecular testing, so if you can afford molecular testing, you actually default to the molecular testing. So if the molecular testing shows high risk genes, then you do the diagnostic lobectomy. But if it doesn't show high risk genes, you are fortunate enough to be able to afford molecular testing, and it doesn't show high risk genes, and you don't need to do any surgery. All right, so
and
that's
just
how we avoid surgery. But if you can't afford molecular testing, then you and the FNAC comes back showing the same thing, then you will need to do diagnostic lobectomy.
and just to confirm the diagnostic lobectomy. So intraoperatively, we're going to take out that lobe and we send a frozen section for them to assess it for
Not frozen
possible
section. No,
invasion.
no, 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 no. You send it off. Not frozen section for histology. Regular,
Okay.
normal, regular histology. Histology is gonna tell you if you have capsular invasion, etc.
Okay. And it's a two operations the patient gets. So if it is that it's confirmed capsular or tubular invasion, sorry.
Yes, if you rotate long enough on ENT or general surgery, you will see that some patients will come in for what we call completion thyroidectomy.
Yes.
So if it comes back showing follicular carcinoma, patient will be booked for completion thyroidectomy. You probably have heard that term before. This is a
Yes,
scenario
yes.
in which they will get completion thyroidectomy. All
Thank you,
right,
Doc.
no problem. And okay, so in terms of determining whether or not patients get ablative therapy, also they have different scores, stratification, classification, the MACEs and ages and all those fancy stuff that you look on mitosis and different parameters to determine how aggressive the basically like grade and those kind of things to determine how aggressive the tumor is, and those can guide you whether to in determining whether or not the patient requires ages, aims, yeah, whether or not they require ablative therapy. All
Quick
right.
question. Last question before.
All right.
So when I was learning on surgery, they were saying that typically in patients who have compressive symptoms or signs of local regionally advanced disease, you do an early CT or MRI of the area. Would that be important to mention in your discussion?
Yes, absolutely. If you have a patient with Bethesda 5, or if you do a Bethesda 3, 4, and it comes back indeterminate, and you do a diagnostic lobectomy, come back showing follicular carcinoma, once you have a diagnosis of cancer, you should do staging. All right. Yes, we erroneously bypassed that. But yes, once you have a diagnosis of cancer, staging is done. And by staging, what we do?
We can do CT or MRI. We can also do bone scintigraphy, bone scan in order to see bone myths and stuff like that. CT cap, bone scan.
Neck also. Neck, chest, abdomen, pelvis.
Okay.
And yes, bone scan if indicated.
Thanks.
All right. Yeah, man. So that's it for today. Gonna have to run. Sorry.
Thank you, Doc.
Yeah, man. So next week.
Thank you, sir.
All right, cool.
Doc,
Yeah,
what's the
man.
topic for next week?
I think AAA. Yeah, maybe AAA
Okay.
and AV fistula. All right. So see you.